My name is Dr. Wu. I've been teaching medical students on one-on-one basis for the last 30 years. I give the same lecture to them every time, so I decided to have it taped. So anesthesia. Anesthesia means the loss of sensation. And the way we get sensation is the receptor receives sensation, go through the transportation system, go to the thalamus, synapse in the thalamus, and go to the cortex. And the cortex interprets sensation. In part 1 of the lecture, so 2 ways of losing sensation. One is to surface the conduction. The second way is to scramble the interpretation. In part 1 of my lectures, I have talked about using local anesthetic to surface the conduction. Today is part 2. Now sensation. We have many sensations. Pain is one of the sensations we have. Touch. Smell. Temperature. Sight. And then hearing. Hearing, the last to go. Now pain sensation. Pain sensation usually, to everybody, to most people in fact, is nauseous. And what did noxious sensation do? It produces sympathetic stimulation. And with sympathetic stimulation, you have increase in blood pressure and increase in heart rate. In fact, that's 2 parameters we use to judge whether the patient has any pain. If the patient has pain, you increase in blood pressure or heart rate. There are other things that could measure pain sensation, such as we use a BIS or something similar, which measure the electroencephalogram of the brain, and the BIS has the 0 to 100. And then about 50 is the point when people lose most of sensation and supposed to be adequate anesthesia or analgesia. But it's expensive, have a lot of artifacts, so rarely used. So what we want to is to control pain, so that you don't have this happen. How do we control pain? First, we have to know the pain pathway. This is the typical pain pathway. The receptor goes to the spinal cord, thalamus, and cortex. This is called spinal thalamic tract. Thalamic tract. And it conducts pain. So when you cut the spinal cord this way, the spinal cord will look something like that. You got a central canal, gray matter, white matter, gray, and posterior, anterior. Afferent comes in, posterior ganglion, synapse here, go up to the thalamus. Now this synapse, for this tract, at the tract 2 to 3 layers, it's called substantia. Gelatulosa. This area here. In this area, you have the mu receptor or the kappa receptor. They call it kappa receptor or mu receptor. mainly mu receptor and some kappa receptor. What does it do is it transmits neurotransmitter across the synapse. A neurotransmitter is called a pain substance. So if we block the pain P substance on the mu receptor, then the spinal thalamic tract will be not complete. What do you use to block those transmitters? We use opioid. Opioid consists of morphine, like substance. There are other substances, morphine-like substance. For example, we use fentanyl. Alfentanil, remifentanil, sulfentanil. Some other things like hydromorphone, or even codeine, which is converted to morphine eventually. What this agent do is, this agent will block the P substance in the mu or kappa receptor, then you don't have the completion of the spinal thalamic tract, then you don't have pain. Okay? Now the other area where we have the mu receptor is called periductal gray. Periductal gray matter. Periductal gray matter is somewhere in there between the third and fourth ventricle here. And there's two areas where you have substantial mu receptors. That's why when we use spinal opioid in here for pain control, this is the closest place where the opioid will get to the mu receptor and block the pain pathway. The last lectures we use local anesthetic, which block the nerve here. But this one we use a specific agent which block only the spinal thalamic tract. Now, of course, all depending on the dosage. Some people require higher dosage, some people require lower dosage. And it depending on the potency of each drug. If morphine is 1, this is about 100 times, something like that. Okay. So that's another way of losing sensation, and this way is more specific just for pain. Now, although it only blocks the mu receptors, but as the dosage go up, you also block some of the CNS system, like somnolence, and drowsiness. This agent, opioid, also depress the respiratory center. In the cerebellum. So, giving opioid, you have to watch for sedation and respiratory depression. Usually, the respiratory rate go down first before the tidal volume goes down. So, that's another way of losing sensation, but more specific.